My name is Brian Weinshenker. I'm a professor of neurology at Mayo Clinic in Rochester, Minnesota. And I'm very, very pleased to be speaking at this first ever virtual Consortium of MS Centers meeting. I'd like to congratulate June Halper and her teams. I know this is very difficult times with our COVID epidemic, but I had entire confidence in June Halper that when she's handed lemons, she knows how to make lemonade. And I'm very honored to give this talk on emerging treatments for NMO spectrum disorders. It's a very exciting time for neuromyelitis optica now that we have the first regulatory approved treatment for neuromyelitis optica. And it's very likely that within the next year, 2 further treatments that we'll discuss today will be approved. So this is a very exciting time. And I think it's opportune to examine how we got to where we are. What are the data that have emerged from these phase 3 clinical trials, and examine briefly where we are going in the current and the new therapeutic milieu. This activity is approved for CME credit in support of improving patient care. The Consortium of MS Centers is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. And this activity should qualify for 1 hour of credit for physicians, for nurses, for pharmacists, PAs, nurse practitioners, social workers, and psychologists. I hope we haven't forgotten anybody. June Halper and her team certainly haven't forgotten anyone. These are my financial disclosures, and I'll give you a second to look at these. The learning objectives for today are to recognize key objectives of treatment of neuromyelitis optica spectrum disorders, understand the pathophysiology and be aware of targetable elements of the pathophysiology and potential treatment strategies. We will review data from phase 3 clinical trials of eculizumab, inebilizumab, and sartrilizumab, all of which concluded in 2019, and we'll consider the impact of the new therapeutic milieu given the recent and forthcoming expected approvals on future clinical investigation of neuromyelitis optica spectrum disorders. What are our treatment objectives for neuromyelitis optica spectrum disorder? First and foremost, we want to prevent attacks of the disease. One thing that I think we all appreciate, and as the expression goes, it's better not to spill the milk than try to take the spilled milk and put it back in the bottle. So in the context of neuromyelitis optica, this means that we want to prevent attacks. And there are a couple of different strategies by which we can do so. We've concentrated, especially now that we understand the pathogenesis of neuromyelitis optica, especially the type associated with AQP4 IgG antibodies, aquaporin 4 autoantibodies, which is the most severe form of neuromyelitis optica. We understand that the key elements are aquaporin 4 expression, the autoantibody directed to aquaporin 4, and complement. In some very elegant passive transfer experiments that have been done, it's been clearly shown that if any one of these components is missing, essentially attacks of neuromyelitis optica can be abrogated. In aquaporin 4 knockout mice, there's virtually no pathology. If aquaporin 4 IgG is eliminated, there's no pathology. And unless human complement is given along with the aquaporin 4 antibody, essentially no pathology is detected. Now, we recognize there are a number of important downstream mediators of inflammatory damage, especially neutrophils and eosinophils. And in these experimental transfer experiments, interfering with either neutrophil function or eosinophil function or some of their inflammatory products can abrogate disease. So this has been the principal focus, I think, of investigation. But we now certainly recognize that aquaporin 4 IgG gets there in some way. It's an IgG1 antibody, which is dependent on T cell help. And this means that it's very important that aquaporin 4 antigen is recognized, that T cells are activated, which help B cells. This results in antibody production. And theoretically, working on this upstream end by either inhibiting T cell function or contributing to a milieu of tolerance rather than immune activation might theoretically be able to modulate inflammatory activity in neuromyelitis optica, and we'll talk about this at the end of the talk. Not only do we wish to prevent attacks, we would love to be able to eliminate attacks entirely, but for those attacks that might break through, it would be great if we could also mitigate the severity of these attacks. We'd like to facilitate early and complete recovery, and by mitigating attack severity, we might be able to do so. But other mechanisms to restore function would be ideal. Unfortunately, we don't have very good methods for doing so at the present time. Largely, rehabilitation strategies are what we use. We would love to have something even more effective. And for symptoms that persist in patients who are disabled by the condition, or in the context of acute attacks such as paroxysmal tonic spasms, we would like to reduce symptoms, but this aspect is beyond the scope of the discussion today. What is the history of treatment in neuromyelitis optica spectrum disorder? Until the late 1990s, most cases of neuromyelitis optica were largely unrecognized. Most were diagnosed and treated as MS. And increasingly, we've come to appreciate that treatments for multiple sclerosis, such as interferon beta, glatiramer acetate, and many others, such as natalizumab, are either ineffective or in some instances potentially harmful to patients with neuromyelitis optica. So this is the situation we were in just 20 years ago. Raoul Mandler, then at George Washington University, reported in 1998 that azathioprine in a very small series of patients was apparently highly effective. And I think this was a landmark paper in retrospect that ushered in at least the concept that we could effectively treat neuromyelitis optica with medications that suppress the immune system. I and my colleagues at Mayo Clinic conducted a study of plasma exchange in severe attacks of central nervous system demyelinating disease. A number of the patients included in that study had neuromyelitis optica or had severe attacks of transverse myelitis, which could well have been neuromyelitis optica spectrum disorders. And we were able to show that even in patients who failed corticosteroids and had severe disability, in about half of patients, we could salvage their neurologic function by treatment with plasma exchange. And this has been really a very critical treatment for patients with acute attacks of neuromyelitis optica. Another landmark study was published in 2005, a small study in 8 patients by Bruce Cree at University of California at San Francisco. And he showed that rituximab was highly effective in prevention of attacks. The majority of patients were attack-free over a brief period of follow-up, And disability significantly improved in a number of those patients who were treated shortly after they had attacks of neuromyelitis optica. This led to a number of consensus statements sponsored by a number of organizations in the United States, by the Guthrie-Jackson Foundation, in France by a consortium called NMOSD, the European Academy of Neurology, and others, that gave us essentially what has been our treatment for neuromyelitis optica for the past 2 decades, at least until this past summer. And the cornerstone of treatment was immunosuppression. Early treatments that were used were azathioprine, mycophenolate mofetil, and prednisone, typically given over extended periods of time in low dose. And rituximab gained significant credibility with use, and all of these were advocated as potential first-line treatments for prevention of attacks. Of course, for acute treatment, when an attack occurred, corticosteroids still remain to be the mainstay of treatment, but in patients failing corticosteroids, I think there is now widespread acceptance of plasma exchange as a potential effective rescue therapy. And we have a number of symptomatic treatments for pain, spasticity, paroxysmal tonic spasms that are quite frequent following attacks of neuromyelitis optica. And of course, physical therapy is still a very important aspect of management, particularly in those patients who have ongoing and persistent impairments and disability. I'm going to turn to describe the pathophysiology of aquaporin 4 IgG seropositive neuromyelitis optica, because an understanding of this pathophysiology has really been instrumental in proposing candidates for treatment, many of which have been highly effective, that is, treatments targeting certain aspects of the pathophysiology. And typically, one would have started with aquaporin 4 IgG 20 years ago when the antibody was first discovered and was found in passive transfer experiments to reproduce much of the pathology and typical pathology of human neuromyelitis optica in experimental animals. But as I mentioned before, this is an IgG1 antibody, and we now recognize that this is dependent on T cells. You see a T cell here that is recognizing an aquaporin 4 peptide in the context of MHC class 2, expressed on an antigen presenting cell. And this results in T cell activation. And one thing that is now quite accepted in neuromyelitis optica is there is a number of characteristics of Th17-mediated pathology in the pathology, the neutrophil and eosinophil infiltration, quite typical of Th17 type pathology. And many of the cytokines that are expressed in neuromyelitis optica, very high levels of IL-6, something that is seen in Th17-mediated pathology. Now, tolerance induction, we'll be talking about immune tolerance at the end, is a potential strategy here. These T cells offer help to B cells, which recognize aquaporin 4 antigen, full aquaporin 4, which we know is expressed on a number of tissues in the lung, in the kidney, in the gut, and elsewhere. And interestingly, in rare patients with neuromyelitis optica, has been expressed on certain tumors. And these tumors, which express aquaporin 4, presumably in a paraneoplastic context, sometimes can lead to inflammation in the tumor that has been detected in these tumors, and aquaporin 4 antibodies. Now, this is a relatively uncommon situation. The vast majority of patients with neuromyelitis optica do not have tumors, but I think it does provide some evidence of the importance of peripheral expression of aquaporin 4 on generating the immune response that leads to neuromyelitis optica. These B cells then differentiate into plasmablasts and mature plasma cells, and it has been shown that they are dependent on trophic activity from IL-6. The mainstay of treatment, azathioprine and mycophenolate, has been immunosuppression, but one of the agents that we'll talk about is sartrilizumab, which blocks the IL-6 receptor. And IL-6, as I mentioned, is important in trophic function for plasmablasts, as well as being an important product, an important aspect in Th17 differentiation. We now come to the strategy of trying to deplete B cells with monoclonal antibodies, which has also been a mainstay of treatment. Rituximab is such an antibody, an anti-CD20, and we'll be talking about an anti-CD19 antibody in ebolizumab in upcoming slides. The plasma cells and plasmablasts express or produce anti-aquaporin antibodies, which are IgG1 antibodies, which then, and these antibodies can be treated, as I mentioned, by depletion with plasma exchange, which is the acute treatment that we use for neuromyelitis optica. These antibodies can enter the blood-brain barrier through a small breach or area where the blood-brain barrier is deficient. For example, the area postrema, which might be some reason why patients are prone to getting lesions in the medulla that cause intractable vomiting and hiccup. But we know that sartrilizumab also has effects at restoring the integrity of the blood-brain barrier. So blood-brain barrier is another important strategy. As soon as these antibodies cross into the central nervous system, they immediately encounter these astrocyte foot processes, which are long extensions of the supporting cells astrocytes, which are the main target of neuromyelitis optica, which are wrapped around these blood vessels. Here you see this catcher's mitt configuration of an astrocyte foot process that on its surface, on FAS, expresses M1 and M23 isoforms, two different isoforms of aquaporin 4, which is encoded on chromosome 8. And these two isoforms are transported down to the astrocyte end feet, where they complex with dystrophin. And they can form very large aggregates. As it turns out, the shorter isoform, M23, which is 22 amino acids shorter than M1, if it is overly expressed in a cell, those aggregates with a large number of M23 shown in black here tend to form large supramolecular aggregates. And we've learned that in the optic nerve and spinal cord, M23 tends to be particularly overexpressed, and in general, aquaporin 4 tends to be relatively overexpressed compared to other parts of the central nervous system, which give us some clue as to why the optic nerve and spinal cord tend to be particularly affected. The aggregates that occur probably favor the conformation of these green autoantibodies, which facilitate binding of C1q complement and activation of the complement cascade. One potential approach to treatment that has been proposed is altering the aquaporin 4 antibodies to generate antibodies that are incapable of activating complement and also incapable of attracting natural killer cells. And this is one strategy. Another strategy is to search for small molecule competitive inhibitors of aquaporin 4 binding, and these might theoretically be effective as well. Complement is activated. It leads to activation of the entire complement cascade and the membrane attack complex, which is able to cause cell lysis, but also releases chemotactic fragments, which can attract neutrophils and eosinophils. Here's where one of the treatments that we'll talk about, a complement inhibitor, comes into place, and there are a few that have been considered for treatment. Neutrophils and eosinophils can be blocked. sorry. Neutrophils and eosinophils can be blocked by a variety of agents which have been studied in experimental studies. And one other action of aquaporin 4 is the fact that it's able to modulate, the antibody is able to modulate aquaporin 4 off the surface of the astrocyte foot process, where it becomes internalized and gets degraded in endosomes. One molecule that is linked to aquaporin 4 is excitatory amino acid transporter 2, which is involved in clearance of glutamate. And so one would predict an excess of glutamate, which seems to be important. Another action of aquaporin 4 that has been shown in experimental studies is its ability to act as a danger signal, which turns on certain cytokine pathways, such as the NF-kappa B pathway within the central nervous system, and results in a number of inflammatory mediators, which may be important even when complement doesn't get activated. But the main pathology in terms of attacks seems to be associated with complement activation. So to summarize the treatment strategies, they can be T-cell directed, either tolerization, anti-cytokine strategies such as anti-IL-6, or even strategies such as stem cell transplantation. They can be B-cell directed. We have anti-CD20 treatments that we use in practice. We'll talk about anti-CD19, and there's been a small study of a proteasome inhibitor that probably is more effective on mature plasma cells, or bortezomib. I won't talk about that small study, that uncontrolled study that has been reported. Antibody depletion, we talked about plasma exchange, targeting blood-brain barrier deficiencies, and a number of strategies such as bevacizumab have been used, which is an anti-VEGF monoclonal. We talked about IL-6 inhibition having an important effect also at the blood-brain barrier. We can block AQP4 IgG engagement with aquaporimab or small molecules, and we can mitigate downstream effectors of NMO pathology, such as complement inhibitors. We'll talk about eculizumab. C1 esterase inhibitors have also been studied in a small study, small uncontrolled study, blockers of neutrophils, eosinophils, and glutamate. So these are various strategies that can be used and are being studied. Flash news in 2019, 4 phase 3 clinical trials have been completed of 3 different agents: eculizumab, inebilizumab, and sartrilizumab. And we now have the first regulatory approved treatment of neuromyelitis optica spectrum disorder in aquaporin 4 IgG seropositive patients. We'll talk about the fact that these agents have not proved as promising, albeit we can't say this definitively in the seronegative patients, but certainly the greatest efficacy is seen in the seropositive patients. And eculizumab received approval in the US in June 2019, in Europe in August 2019, and in Japan in November 2019. Natalia Rost of the Mass General Hospital and chair of the AAN Scientific Committee said 2019 is the year of NMO. And borrowing from Winston Churchill, who said after World War II was over, we may allow ourselves a brief period of rejoicing, I think it is a time that the NMO community can proudly say that within 20 years, we've gone from a disease that many people argued might not exist, for which we did not have a diagnostic biomarker, for which we really didn't recognize most cases, and we've been able to advance on all those fronts and successfully recruit and conduct 4 different therapeutic trials with the aid, important aid of industry partners, and come up with a drug that's been approved and 2 others that seem very promising, at least, for approval. It wasn't easy, though. It was very costly. These trials were conducted at many sites in many countries. An estimate that I had from Dr. Ellie Katz, who was a key person running the MedImmune Viela Bio study of inebilizumab, is that the cost was approximately $50 million. Eculizumab study was held at 70 sites in 18 countries. Inebilizumab study at 99 sites in 24 countries. It took 3.5 years to enroll 143 subjects to observe 23 protocol-defined relapses in the eculizumab study. And this was in large part because of the ethics of conducting studies in neuromyelitis optica that were hotly debated before these studies were initiated. And to make the drugs ethical, we could not allow a patient to have more than one event before they exited the randomized controlled phase of the study and entered open label extension. And therefore, each patient contributed only a single event and data point. So while we've learned a great deal about treatment in neuromyelitis optica, we've done so with very few data points. And of course, this makes it very costly and difficult. Furthermore, a high proportion of the events that patients reported or that individual sites reported as potential relapses were not adjudicated by adjudication committees as protocol-defined relapses. Only 33% of events, 33% of events were not adjudicated amongst reported events in the inebilizumab study, and 47% in the eculizumab study. But even though the number of relapses were fewer than planned, and one of the studies was terminated prematurely because of overwhelming efficacy, another one simply because it seemed as if it would not be feasible to persist in the study until the planned number of relapses were actually observed, it turned out that the efficacy of treatments that was being studied was much greater than estimated. And therefore, we have robustly positive results for all the studies, in spite of the difficulties with recruitment and identifying relapses. In one slide, I'm going to summarize for you the key results from all of the different clinical trials. Now, this is not to say that you should compare across columns, because as we'll talk about, there are substantial differences in the enrollment criteria, in the criteria for attacks, in the proportion of patients who are AQP4 positive, which it turns out was a very, very key finding in analyzing the results. So many different differences in the study protocols that make it very difficult to compare across columns. But these were all placebo-controlled studies. In some cases, they were added on to some background immune suppressive treatment. In others, they were pure placebo and patients were not allowed to be on other immunotherapy. But I will go over the key results from these 4 clinical trials. The first column is the PREVENT study of eculizumab, a complement inhibitor, an anti-C5 drug. The second column, the N-momentum study of inebilizumab, which is an anti-CD19 monoclonal. And the third and fourth columns are clinical trials of sartrilizumab, an anti-IL-6 receptor inhibitors. The first one reported Sakura Sky. In this study, patients were allowed to remain on background immune suppressive treatment, whereas in Sakura Star, it was a pure placebo. Background immunosuppressive treatment was not allowed. I should mention that in the eculizumab study, the PREVENT study, background immunosuppression treatment was allowed, whereas in the inebilizumab study, the N-momentum study, it was not allowed. So patients were either on active treatment or placebo with no background immunosuppressive treatment. Let's look at the key outcome measure. The principal outcome in all of these studies was time to first event, And this was expressed in terms of the reduction in relapses. In PREVENT study, it was 94.2%. In the N-Momentum study, it was 73%, Sakura Sky 62%, and Sakura Star 55%. But as I mentioned, in one of these studies, that is the eculizumab study, only patients who were seropositive for aquaporin 4 were allowed. In the eculizumab study, both seropositive and seronegative patients were admitted, but it was a relatively small number of patients, 18 patients out of 230 that were seronegative. Whereas in the Sakura Sky and Sakura Star, about a third of the patients were seronegative. So to make things somewhat more comparable across, what I've done is highlighted in red font the patients who were aquaporin 4 positive. So in the aquaporin 4 IgG seropositive group, 94% reduction of attacks. In PREVENT, 77% in evolizumab, 79% in Sakura Sky of sartolizumab, 74% in Sakura Star. Looking at the proportion of patients who were relapse-free is rather complicated because of different durations of the of the randomized phase of the clinical trials. The shortest was in evolizumab, which was background therapy was not allowed, which is, and for the ethics of the study, they looked at relapse-free at 28 weeks. You can see that it was 87%, but really, I think if I could summarize all of these, going out as far as 96 weeks in the various agents, we're looking at between 75 and almost 97% of patients being relapse-free in the various studies. In only one of these studies, was there a clear effect on reducing accrual of disability, which was quite significant in the evolizumab study, which was the largest of the studies. So potentially there was more power. Also, patients were not allowed to be on background immunosuppressive treatment, which may have resulted in worse outcomes in the placebo group and have facilitated the ability to detect an effect on disability. That's speculation, but there was an effect on disability in the evolizumab study. The good news from all of the studies is that they appeared to be relatively safe and no major unexpected adverse effects were noted. So what did these trials tell us? First, all three treatments appeared to be highly effective in preventing attacks. I think that assures us that when we have a pretty good understanding of the disease mechanism, we can make very effective selections of potentially effective treatments and get very good results. And another very important point is that in 2 out of the 3 studies that included both seropositive and seronegative patients, the effect was seen primarily in the seropositive, the aquaporin 4 IgG seropositive group. In the Sakura Sky and the Sakura Star study, where a third of the patients were seronegative, although the power is not there to say definitively that there is no benefit in the seronegative group, there really didn't appear to be much signal of benefit. What did these studies not tell us? But we might actually, through further studies, get some insights. We talked about an important goal of treatment being not only to eliminate attacks, that would be, of course, ideal, but to modify and mitigate the severity of attacks that do occur. And in fact, further studies in the eculizumab study were able to show that attack severity was reduced. In a poster that I presented at ECTRIMS 2019, when one examines the proportion of attacks that were severe or major, the ones who were receiving placebo group had a higher proportion of patients that had more severe or major attacks than did the group that had evolizumab. And the other thing that we examined was recovery. and a higher proportion of patients who were on placebo had no recovery from their attack. The overall distribution looks more favorable in the patients who were on inebilizumab. So inebilizumab may have mitigated the severity of attacks. Of course, we're not using placebo in general in our practice. We're using rituximab and other treatments. And what is the comparative efficacy with currently utilized treatments? And unfortunately, we don't have those answers. We don't know how durable the benefits are. The first attack only was studied, and therefore we don't yet have information on the durability of benefits or long-term benefits. And furthermore, even for safety, even though all of these agents look quite favorable in the short term, we don't know about their long-term safety. Have we learned anything about how to conduct clinical trials in the future, identify optimal trial candidates? Looking at patients based on their AQP4 IgG titers does not seem to be a very effective strategy to identify patients at high risk for attacks. And in fact, even looking at their attack history, the frequency of attacks prior to enrollment based on studies that have been done from Oxford in the UK and elsewhere, suggests that we have very limited ability to identify the future attack frequency based on the prior attack frequency. But very interesting poster was presented by Orhun Aktaş based on work from the inebilizumab study. They studied serum GFAP. GFAP is a structural protein. You can think of it like a CK or neurofilament light. We're very familiar with many of the very important studies that are being done on neurofilament light in MS patients. And it has been shown, looking retrospectively at patients who experienced an attack during the clinical trial versus those who did not have an attack, the level of GFAP measured by Simoa techniques, same as is used with neurofilament light, was significantly elevated beyond 3 standard deviations in patients who we learned subsequently developed an attack in this clinical trial. And in fact, the levels were the highest in patients who were within 1 week of that attack. And at the attack visit, 29 out of 37 patients had grossly elevated serum GFAP. This is a logarithmic scale. So this is a very, very large increase that was seen in this measure, which was measured in peripheral blood retrospectively. Furthermore, if one looks at the risk of developing an attack based on baseline SGFAP, those with a level of greater than 171, 3 standard deviations above the mean, had a significantly elevated risk of having an attack. Furthermore, this seemed to give us some way of assessing attack severity, or at least it's promising, in the sense that the placebo group during an attack had a very great elevation in the serum GFAP. Again, this is a logarithmic scale compared to the inebilizumab group, where the elevation in GFAP was very much mitigated. So we've learned before that the clinical severity of attacks seemed to be less. The effect on looking at GFAP, comparing patients who are on inebilizumab and placebo in terms of their GFAP elevation, also seems to be quite important and significant. But we still have a hard time identifying optimal responders. But one thing that seemed to become fairly clear, although we still can't say it definitively, is that patients who are seronegative for aquaporin 4 antibodies were much less likely to benefit. So this has raised a number of difficult issues about how to use the new drugs. We had to await a regulatory approval. As I mentioned, eculizumab has been FDA approved and also approved in Europe and Japan. We await regulatory approval for inebilizumab and sartrilizumab, but hopefully within the next year we will have an answer. In patients who are stable on treatment, should we be taking them off their treatments and switching to regulatory approved drugs? I think this is a very difficult issue. And it will depend on many things, including cost and insurance coverage. If we don't do this on every patient, do we do this on all new patients? Certainly, I think in patients who fail existing treatments, we have a number of new, very potent drugs which offer a number of good options. But I think this question of whom we should consider for the new treatments is an open one. It would be ideal if we could individualize treatment based on drug mechanism. Potentially, these drugs acting at slightly different points could have even further additive effects, although one could argue, how will it be possible to show an improvement on 80 to 90% attack suppression? We'll talk about that in a minute. We certainly want to consider individual comorbidities and safety risks, but as I mentioned, these drugs thus far all appear to be fairly safe, but of course, they weren't studied in the COVID era, and a number of new considerations have come up, and these are going to be open questions as now in the era of pandemics. Would their safety profile be as good and as comparable? And of course, cost and convenience, because there are differences there. Sartrilizumab, for example, is self-administered by subcutaneous subcutaneous injection. Inebilizumab is given intravenously, but generally every 6 months, whereas eculizumab is administered intravenously, but every 2 weeks. So there are differences in convenience. And of course, as I mentioned before, what do we do with the seronegative patients? We're tempted to compare the efficacy of drugs, but as I mentioned before, in these different studies, there were different enrollment criteria which influence power and effect size. Some patients had baseline immunotherapy. Now, what effect might that have had? And you might say, well, potentially there could have been additive effects between the active treatment and the baseline immunotherapy. But if we consider these data published on eculizumab, and the top shows patients not receiving concomitant immunosuppressive treatment, the bottom shows patients who receive concomitant immunosuppressive therapy. And in terms of the proportion attack-free on the active treatment, eculizumab, really not much different. Very slightly better in the patients who are not receiving concomitant immunosuppressive treatment, but the big difference is the placebo group, as one might expect, did significantly better in the patients receiving concomitant immunosuppressive therapy. So the difference between these two curves, the effect size, would probably be suppressed by the fact that the patients were on background immunosuppression. One would guess from this that if all of the patients were not receiving concomitant immunosuppressive therapy, that the results would have even been more impressive in terms of effect size in the eculizumab study. I mentioned different attack definitions, so that's going to be very important to get our heads together to get a consistent definition of attacks, and there were different durations of the randomized phase. What are the implications for future clinical trials? Many who argued vociferously that placebo-controlled trials were ethical might now be less convinced now that we have regulatory approved treatments. And how can we possibly power a head-to-head study? And we had difficulty enrolling placebo-controlled studies, but how could we power a head-to-head study when we have eculizumab and all of our various agents that we talked about in the phase 3 clinical trials achieving 70 to 90% reduction in attacks? Seems simply not feasible. So we're going to need to enhance our endpoints. We're going to need to have absolutely no noise enhance consistency of definition of attacks, and application of those definitions to facilitate better comparisons. We're going to need more sensitive endpoints. We're going to not only have to look at attack or no attack, but also consider fine variations of attack severity to improve our sensitivity. And we need to consider other potential outcomes. There are potentially some, although I think they are only in their infancy, understanding the effects of aquaporin 4 IgG, but we're going to need to move in that direction. What are the remaining unmet needs? Well, although the new treatments seem to achieve very high degree of suppression of attacks, attacks continue to occur, so we need better and more consistently effective salvage treatments for those attacks that do occur. We need to identify the risk of having an attack before those attacks occur to allow for modification or escalation of treatments. And I think GFAP is a very promising biomarker. There may be others. We need treatments for the seronegative patients, including patients who are seropositive for MOG antibodies. It appears that the phase 3 clinical trials do not provide us adequate options for those patients. And we need treatments that address the cause of the disease and cure the disease, like tolerization. Speaking of tolerization, it's been the subject of a great deal of interest. This was a 2-part review that appeared in Neuroimmunology and Neuroinflammation. The first part led by Larry Steinman and the second part by Amit Bar-Or. And they proposed a series of strategies, and really too many for me to mention them all, but they utilize basically either enhancement of regulatory function, T and B regulatory function, or strategies to generate energy or lack of immune reactivity, preferably in a antigen-specific way. And this was done by a variety of, or this has been suggested that it could be done by a variety of potential strategies, including vaccination or modified presentations, such as gut presentation of antigen, or doing something as straightforward as taking and isolating T regs or B regs and expanding them ex vivo and reinfusing them. This has been a strategy that has been exploited in other diseases, such as type 1 diabetes, or strategies that I'll outline on the next slide. So here is an example of a study. It's a very small study, and it's certainly preliminary, but I think provides some proof of concept. This was conducted by Pablo Villaslada and his colleagues in Barcelona. They basically isolated dendritic cells, stimulated them with a cytokine cocktail to render them tolerogenic. And they also peptide loaded them, exposed them to peptides, a series of myelin peptides, and also aquaporin 4 peptides. This was a study conducted both in MS patients and patients with neuromyelitis optica. And the patients remained stable clinically, and they also were able to detect production of IL-10 in PBMCs that were stimulated by these peptides after this protocol, as well as an increased frequency in a regulatory T cell phenotype. Another study conducted in macaques, so not humans, but in macaques, used a model of experimental autoimmune encephalomyelitis, EAE, that was induced by recombinant human MOG, which is, of course, the important antigen in many patients with seronegative neuromyelitis optica spectrum disorder. And they treated these patients with an intradermal antibody, recombinant antibody, directed to a dendritic cell receptor that was fused either to MOG, or as a control, they used a different antigen, prostate-specific antigen. And they were able to show both beneficial clinical effects and protection against EAE by those treated with the intradermal antibody that was bound to MOG, but not to PSA. And furthermore, they were able to show that it induced regulatory MOG-specific lymphocytes, and these were able to, and it favored synthesis of TGF-beta and IL-8 after challenge with recombinant MOG. So again, some proof of concept that these are not just theoretical treatments, but potentially practical treatments that would be worth evaluating further. I don't think this can be done in the setting of acute raging neuromyelitis optica, but in stable patients who are stable for a number of years, where we might be considering de-escalating or discontinuing treatments, potentially treatment with these agents studied in a controlled way, and then some randomized de-escalation of primary treatment might be a strategy to evaluate these treatments. So in conclusion, I've shown you the first class 1 evidence that we have in neuromyelitis optica for 3 different treatments: inebilizumab, eculizumab, and sartrilizumab. All 3, in a robust way, reduced attack frequency, and 2 appeared to reduce severity of attacks. But none of them represent a cure. There are unmet needs. We need more specific, safer, more effective, less costly drugs, and we need drugs that we establish long-term efficacy. It'd be nice if it was the drugs we currently have, but that's going to be, of course, an important need because none of these treatments are curative. We need new, more sensitive and informative relapse indicators, and I'm very encouraged by the data that's being presented on serum GFAP. Tolerization studies promise long-term, possibly safer immunomodulation, but we need new investigative strategies along the lines that I've hinted at. And on that note, I'd like to end, and thank you very much for your attention. And again, congratulations to June Halper and her group.